Okay. So we're going to start with acute rheumatic fever, which, as you know, is an inflammatory disorder, which is a complication of untreated group A strep pharyngitis. The peak age of rheumatic fever is the same as the peak age of group A strep pharyngitis, so 5 to 15 years. This is school-age children usually. It has a seasonal predilection in the winter and the spring, just like pharyngitis, and it usually follows outbreaks of group A strep pharyngitis as well. And we know that antimicrobial treatment before the 9th day of the symptoms of acute pharyngitis and treatment for 10 days completely prevents initial attacks of acute rheumatic fever. Long-term prevention of group A strep pharyngitis will also prevent recurrences, and we'll talk about that. Although we see little acute rheumatic fever, back in the 1980s, there was a pretty dramatic resurgence in the United States, mainly in Utah, Ohio, Pennsylvania, and in San Diego. And this was proposed to be due to increased prevalence of the rheumatogenic strains, which are the highly mucoid colonies of group A strep. And you don't need to remember the specific serotypes, but these are the ones that have strongly been associated with acute rheumatic fever. There is a genetic predisposition, and this is an immunologic mimicry phenomenon where there's cross-reactivity between antigenic components of group A strep and heart, brain, and joint tissue. Okay, so we're going to start with a question. An 8-year-old boy is brought to your office because of joint pains for the past week. He initially had a swollen and painful right knee 7 days ago and then developed painful swelling in the left knee 4 days later. The right knee is much improved now, but his left elbow began hurting yesterday. His parents vaguely recall he had a sore throat and fever 3 weeks ago that resolved over 2 to 3 days without treatment, and he was otherwise well until the onset of his joint pain. His vital signs are normal. He's afebrile. His left knee is swollen and very tender to palpation. The right knee is only mildly swollen, and the left elbow also has mild swelling and tenderness. There's no audible murmurs or rubs on exam and has no rashes. His CBC is normal, and his SED rate is 120. So the question is, of the following sets of additional clinical findings and test results, the set that would fulfill the Jones criteria for the diagnosis of rheumatic fever is development of erythema nodosum in the lower legs plus an elevated ASO titer, mitral valve regurg on echo plus an elevated anti-deoxyribonuclease B titer, new daily fevers plus an elevated CRP, new joint pain without redness or swelling or arthralgia in the right elbow plus an elevated ASO, or a prolonged PR interval on ECG plus an elevated ASO titer. So which of those would you need for this child to fulfill the Jones criteria? Wow, okay. So the correct answer is E, prolonged PR interval on EKG plus an elevated ASO titer. So it looks like we need to review this. Okay, so for the diagnosis of acute rheumatic fever, you need 2 major criteria, or 1 major and 1 minor criteria, plus supporting evidence of an antecedent group A strep infection. So just to review the major criteria, and we'll go over these in detail, are carditis, polyarthritis, chorea, erythema marginatum, not erythema nodosum, and subcutaneous nodules. The minor criteria can be either clinical or laboratory. The clinical one are arthralgia, but you can't use this as a minor when arthritis is a major, and fever, which is typically high in the early course of the illness. And then the laboratory findings that are considered minor criteria are elevated acute phase reactants, which this child had, and prolonged PR interval, okay? So this is just to show you the prolonged PR interval is a minor criteria. And then supporting evidence of antecedent group A strep can either be a positive throat culture or rapid antigen test, which is only present 10 to 20% of the time, because remember that about 1/3 of patients do not recall a history of pharyngitis. and then an elevated or rising streptococcal antibody titer, which can be either an ASO or an anti-DNase B. And this is the most common way to prove somebody's had a recent strep infection. So migratory polyarthritis is the most common feature of acute rheumatic fever, present in about 75% of patients. This usually involves the large joints, and these joints are hot, tender, red, swollen, and exquisitely tender. The migratory nature is classic. So if they're going to give you a case of rheumatic fever, they're going to have to classically describe the migratory nature in the large joints. These are not deforming or associated with any chronic changes, and the arthritis usually responds dramatically to non-steroidals, anti-inflammatory, and this can actually be used diagnostically to make the diagnosis. This is the differential. The main one is rheumatoid arthritis. These children are usually younger, and the joint pain is less relative to the findings. So carditis is the most serious manifestation of ARF, and it virtually accounts for all the morbidity and mortality associated with rheumatic fever, and is present about 50 to 60% of cases. And the carditis usually is a pancarditis, which is a valvulitis. So without a valvulitis, without involvement of the valves, you really cannot call it carditis. And it's usually insufficiency, usually mitral, isolated mitral insufficiency is most common, followed by combined aortic and mitral insufficiency, and very rarely just aortic valvular involvement alone. You can have myocarditis and pericarditis, but their presence alone without valvulitis does not make for carditis. So these children usually present with tachycardia and cardiac murmurs with or without rhythm disturbances. They may have a friction rub if they also have pericarditis. Recognize the murmur of mitral regurg, which is the high-pitched apical holosystolic murmur radiating to the axilla. And this may be associated with an apical mid-diastolic murmur of mitral stenosis, which happens later on, and this is the so-called Carey-Coombs murmur. The murmur of aortic regurg is a high-pitched decrescendo diastolic murmur at the upper left sternal border. And they may just describe these to you rather than tell you somebody has mitral regurg or aortic regurg. Cardiomegaly and congestive heart failure may be the presenting features if there is moderate to severe carditis, so be on the lookout for that. And remember that echocardiographic features of valvular regurg without accompanying auscultatory finding does not satisfy the initial Jones criteria, which were revised in 1992. So you really have to hear the murmurs in order to call it carditis. You can't just do an echo. If somebody's got a normal exam, you can't just go by the echocardiographic findings, certainly in this country. These have recently been revised so that in countries where rheumatic fever is much more common, they're a little more lenient about using echocardiographic findings to make the diagnosis of carditis. But for your purposes and purposes of the boards, if they're going to give you a case of rheumatic fever, there's going to be auscultatory findings. You can't just rely on the echo findings. So recurrent episodes of carditis occur with recurrences of rheumatic fever. That's why it's so important to prevent group A strep infections once you make this diagnosis. And valvular disease can predispose you to infective endocarditis and frequently requires valve replacement. So a couple words about Sydenham chorea, which is also a major criteria. This is present in about 10 to 15% of patients, and this can be characterized by any of the following: emotional lability and coordination, poor school performance, uncontrollable movements, facial grimacing, and all of these can be exacerbated by stress and usually disappear with sleep. The onset can be insidious and can occur several months after the acute episode of rheumatic fever. So for this, you do not necessarily need to have proof of an antecedent group A strep infection because it can occur weeks to months after the initial episode. These are some of the maneuvers to make the diagnosis of Sydenham chorea, which are there for you to look at. These rarely result in permanent neurologic sequelae. However, about 20% of children with chorea will develop carditis if they have recurrent group A strep pharyngitis. So they also require continuous prophylaxis, which we'll talk about. This is the differential. There are very few things in children that give you chorea. The big ones are congenital Huntington chorea, Wilson's disease, and lupus. Erythema marginatum is the rash that is associated with rheumatic fever. It's very rare, less than 3% of cases. This is an erythematous or pigmenous macular rash with pale centers, which usually spares the face. This is what it looks like. And then finally, subcutaneous nodules is the final major criteria, incredibly rare, and these are firm nodules usually found along the extensor surfaces near the bony prominences, and these correlate well with rheumatic heart disease, okay? And we recently saw a child with rheumatic carditis who actually had these subcutaneous nodules. So remember again, chorea may be the sole manifestation, and occasionally we will see a kid who has very significant mitral regurgitation, both on exam and on echo, that likely had rheumatic fever because there's no other cause. Previous heart exams would be normal, and these can be indolent and can be picked up months after the initial diagnosis. So for chorea and indolent carditis, you do not necessarily have to prove an antecedent group A strep infection as long as you've ruled out other causes. So the treatment, any child diagnosed with rheumatic fever gets treated with antibiotics for 10 days, usually with oral penicillin, oral amoxicillin, or 1 dose of benzathine penicillin. And this is to get rid of the group A strep from the throat, regardless of whether their throat culture is positive or not. So anyone, once you make the diagnosis, you have to treat the child to eradicate the group A strep. Then depending on whether there's arthritis or carditis, if there's arthritis or carditis without cardiomegaly and without congestive heart failure, the treatment regimen is salicylate for 2 to 4 weeks, and then you taper them over 4 to 6 weeks. Again, usually the response of arthritis is dramatic. With moderate or severe carditis, so if there is cardiomegaly or congestive heart failure, the recommendation is to use corticosteroids for 2 weeks with a slow taper and supportive care. For chorea, it's rest and symptomatic care. Sedative therapy may also be helpful early, like phenobarb, Haldol, and chlorpromazine. So question 2, the same boy in question 1 is found to have a prolonged PR interval, and his ASO titer is 2,000 international units. His echo is normal. He is treated with aspirin and receives a 10-day course of amoxicillin. Of the following, the next best plan for management is benzathine penicillin IM every 4 weeks until age 21, benzathine penicillin IM Q4 weeks until age 40, amoxicillin orally for 1 year after the diagnosis, or amoxicillin orally for 5 years after the diagnosis. Please key in your answers. Bless you. Okay. So the correct answer is A. So these are children who will need prophylaxis with benzathine penicillin, and in this country we give it every 4 weeks, and the 21 years comes from recommendations that I will review. So once you make the diagnosis of rheumatic fever, then you have to prevent subsequent group A strep pharyngitis bouts. Because with every bout of group A strep pharyngitis, that increases the likelihood and severity of rheumatic heart disease, which we'd really like to prevent. So secondary prevention prevents acute pharyngitis in patients at high risk, and we do this with continuous antibiotic prophylaxis. So the recommendations is if you have rheumatic fever without carditis, we prophylax for 5 years since the last episode, or 21 years of age, whichever is longer. If you have rheumatic fever with carditis but without residual heart disease, it's 10 years or 21 years of age, whichever is longer. And then finally, if you have carditis with residual heart disease, those children are really at high risk for worsening carditis. So we prophylax them for 10 years since the last episode, or until they are 40 years of age, whichever one is longer. And we seriously think about lifelong prophylaxis, especially if they have high risk for ongoing exposure to group A strep. And what we like to use is penicillin G benzathine, which is the long-acting penicillin, and we give this every 4 weeks. Alternatively, you can give Pen-VK orally, but because of adherence, we prefer the monthly benzathine. Sulfa does not work to treat group A strep, but it does prevent group A strep pharyngitis, and that is used as an alternative for pen-allergic children. Couple of words about myocarditis. We rarely find a specific etiology finding myocarditis in clinical practice. These are the most common viruses that you should keep in mind. The enteroviruses, especially in the summertime, are most common, but also adenovirus, parvovirus, and some of the herpes viruses, as well as influenza. Rarely as a result of a bacterial infection. There are a couple of parasitic diseases that are strongly associated with myocarditis, so with a good travel history, Chagas disease or Trypanosoma cruzi is the most common cause of myocarditis in South America, and Toxoplasma is a rare cause. This generally peaks in the summer and early fall, again because of the enteroviruses. Neonates and young infants are most susceptible, and neonates especially lack serum-specific antibodies, and that's why they have a more severe presentation. These kids usually present with fatigue, malaise, nonspecific symptoms. They may have chest pain and dyspnea and tachypnea. Nonspecific findings, however, are common in younger children. There's often a preceding viral illness, which is common, and again, for the purposes of the boards, they will give you classic presentations. So they will give you a preceding viral illness and then the nonspecific manifestations to clue you into the diagnosis. Congestive heart failure is found in most children at the time of diagnosis, and so their physical findings are going to be consistent with congestive heart failure. Cardiomegaly is usually found, but may be normal early. The EKG is highly variable. There's usually ST segment changes, T-wave inversions, and conduct disturbances. And on echo, there's going to be dilatation of the chambers and poor contractility. The utility of biopsy is controversial, so they're not going to ask you anything controversial, so they'll stay away from that. The management is with supportive care, managing congestive heart failure, specific antibacterial and antiviral agents if you identify a specific cause, which again is very rare. The role of corticosteroids and IVIG, both of those modalities are used. Their benefit is controversial, so again, they will not ask you about this on the boards. So pericarditis, there are different types of pericarditis that you should be aware of. Certainly purulent pericarditis is the most severe form. This is usually secondary to bacteremia. It's very rare today, mainly because of the H flu vaccine. It can also be caused by Staph aureus, however. More commonly is benign or idiopathic pericarditis, which is usually viral in origin and post-infectious. Granulomatous pericarditis is usually caused by mycobacterial or fungal agents, and the non-infectious causes such as autoimmune, uremia, drug hypersensitivity, and you should also be familiar with the post-pericardiotomy syndrome, which I'll talk about briefly. These kids will generally present with precordial chest pain, which may radiate down the arm and is aggravated by movement. It's worse when supine and relieved when sitting forward. Fever, shortness of breath, and weakness. And on physical exam, you're going to hear muffled heart sounds. These kids are going to be tachycardic, and they're going to have a friction rub. And you want to be aware of signs of tamponade, which is tachycardia, peripheral vasoconstriction, and reduced pulse pressure, and the finding of pulsus paradoxus. The differential is usually pretty specific: pneumonia and pyema are usually easy to differentiate. Post-pericardiotomy syndrome happens within 6 weeks of cardiac surgery, and these kids will usually present again with fever, pain, and a friction rub. This is thought to be an autoimmune process. So if they're clearly giving you this presentation following cardiac surgery, it's likely to be post-pericardiotomy syndrome. There's usually increase in the size of the cardiac shadow. It's usually a globular-shaped heart, and the EKG is going to show generalized ST segment elevations, and echo is most valuable to look for the diagnosis as well as the severity, and this is mainly to see the presence of pericardial fluid. This is pericarditis, mainly ST segment elevation is what you want to look for right here. The management for small effusions, usually supportive care. For large effusions, pericardiocentesis or open drainage. Purulent pericarditis, usually IV antibiotics and drainage of the fluid. And post-pericardiotomy syndrome, aspirin or nonsteroidals, and occasionally corticosteroids. All right, Kawasaki is, as you know, the most common cause of acquired heart disease in the developed world. The cause remains elusive. 80% of cases occur in children less than 5 years of age, more common in males, highest attack rate in Asian children, and as you know, the most serious complication is coronary artery dilatation and aneurysms. So we'll do a question. You're seeing a 27-month-old toddler in the office who has had 5 days of daily fevers to 104 and a red rash on his trunk and extremities. On exam, he's very irritable, tachycardic, and normotensive. You also note that he has cracked, fissured lips, a strawberry tongue, erythema, swelling of his extremities, a polymorphous rash, a 2-centimeter cervical node in his right neck, and bilateral non-exudative conjunctivitis. So pretty classic. So of the following, the most likely laboratory feature to be present at this time in this infant is hyperbilirubinemia, leukocytosis, neutropenia, or thrombocytosis. And the boards are notorious for giving you a classic presentation of something and you're thinking they're going to ask me what the diagnosis is, and then they ask you a different question that presumes that you need to know something about it. So the correct answer is leukocytosis. So a lot of you chose thrombocytosis. Remember, at the initial presentation, day 5, they're not going to have thrombocytosis yet. They're going to have a normal platelet count, okay? So let's review this. So fever for at least 5 days, and then 4 out of the following 5, which we've gone through: non-exudative conjunctivitis, mucous membrane changes, extremity changes, the polymorphous rash, and the lymphadenopathy, and it's not going to be explained by something else. So this is a classic strawberry tongue. This is the polymorphous rash, which can be any type of rash, has been described with Kawasaki except a vesicular rash. If they're describing a vesicular rash, it's not going to be Kawasaki, but everything else can certainly be Kawasaki. Remember, this is non-exudative conjunctivitis. Lymphadenopathy is the least common finding, but when it's there, it's pretty impressive. And extremity changes, which can be extremity swelling, can be palmar or plantar erythema. So the most important complication is obviously the coronary artery aneurysms, which occur in 25% of untreated patients versus 4% if you treat them with IVIG and aspirin. They may also have myocarditis and pericarditis. These children, as you know, are extremely irritable. If you do an LP, they will likely have an aseptic meningitis. GI manifestations are relatively common, especially a hepatitis present in 50%. They may have high drops of the gallbladder as well. These just shows you some of the aneurysms that they may have, which can be large, giant, saccular in nature. And this is just a picture of high drops of the gallbladder, which we see. Urethritis, so sterile pyuria is really common. They may have nonspecific joint complaints. A preceding respiratory illness is common, as is uveitis. So all these children at presentation will have leukocytosis, and they will all have elevated acute phase reactants. Commonly, they will also have anemia, sterile pyuria, transaminitis, hypoalbuminemia, and as we said, CSF pleocytosis. Thrombocytosis, again, you start to see that during the convalescent phase, which is the second week of the illness. So when they usually present on day 5, day 6, their platelet counts are going to be normal. The differential diagnosis, fortunately we don't see a lot of measles, but once we start to see more measles, it's going to be very difficult clinically to distinguish measles from Kawasaki. Group A strep and scarlet fever, Stevens-Johnson's are the ones that I have the most difficulty distinguishing from Kawasaki. So when do you do echoes on these children? You always do them at diagnosis, 1 to 2 weeks after you make the diagnosis, and then 6 to 8 weeks after the fever onset. And if any of these echoes are abnormal, you may need to do them more frequently. But generally, this is the standard as long as they are normal. So for the toddler in the previous question, the most appropriate treatment regimen should include IVIG, 2 grams per kilo, plus low-dose aspirin, high-dose aspirin, low-dose aspirin plus corticosteroids, or high-dose aspirin plus corticosteroids. So this is the child with classic Kawasaki that I presented. Okay, so the right answer is high-dose aspirin because in the initial stage, you actually want the anti-inflammatory response. So the standard regimen is IVIG and high-dose aspirin. Corticosteroids are not used as primary therapy in this country. They have been shown to be of some benefit for high-risk Japanese children, but it is not the standard of care in this country. About 10 to 15% of children do not respond to the first dose of IVIG, and for these children, a second dose is usually effective. Some people do, at this point, use corticosteroids or infliximab. They're not going to ask you about this on the boards as long as you remember IVIG, high-dose aspirin, and when to switch to low-dose aspirin, which is once they are afebrile for 72 hours or at the 14th day of the illness. And at that point, it's the antithrombotic effect that we are looking for. And then we usually stop aspirin at 6 to 8 weeks if the echo is normal and their SED rates have become normal. They are obviously continued for those who have coronary artery aneurysms, and you also may need other antithrombotics, and at that point, the cardiologists are usually very much involved. The peak time to the development of coronary artery aneurysm is usually 2 to 3 weeks after the onset of the fever. These rarely develop after 6 weeks. That's why we're comfortable stopping aspirin at that point. There may be resolution of the artery aneurysms or dilatation 1 year after diagnosis in about half the kids, but those with giant aneurysms are the greatest risk for thrombosis. A few words about incomplete Kawasaki. The clinical presentation is usually with fever and fewer than the 4 principal findings. These are well described and they're usually associated with high morbidity and death. These continue to be a major diagnostic dilemma because other febrile illnesses manifest in a similar way. These are much more common in infants and older children. The features may be particularly subtle, and unfortunately, these kids have a high incidence of coronary artery aneurysms. They usually present with prolonged fever and any combination of the manifestations that we normally see with Kawasaki. It seems that cervical adenopathy may be a prominent feature in these babies, and we've seen several babies with just prolonged fever and cervical lymphadenopathy turn out to actually have Kawasaki. The lab findings are very similar to classic Kawasaki and may be helpful in excluding or enhancing suspicion for incomplete Kawasaki. And unfortunately, echoes often helpful in making the diagnosis because at the time that they're picked up, they usually have coronary artery changes. Distinguishing from viruses, especially adenovirus, can be very difficult. But if you have a child with a purulent conjunctivitis or an exudative pharyngitis, that is much more likely to be adeno than Kawasaki. And perineal desquamation and extremity changes are more likely to be Kawasaki than adenovirus. However, the two can coexist, and there have been reports of adenovirus as well as Kawasaki existing. So just because you find adenovirus, it doesn't mean the child does not have Kawasaki. And this is an algorithm on how you evaluate a child with suspected incomplete Kawasaki, which you can look at. I'm not going to go over it in detail for time's sake. The younger children do worse because they have the actual highest incidence of coronary artery aneurysms. All right, we're going to spend the last couple minutes on infective endocarditis. So children with infective endocarditis are usually going to have risk factors. The most common risk factor is previous congenital heart disease, and the most common ones are VSDs, PDAs, and palliative shunts, valve replacements, and children with pacemakers. Rheumatic heart disease is a significant risk factor for endocarditis. There are children who develop endocarditis without having specific cardiac defects. Usually these are caused by Staph aureus, which we'll review. And then remember, neonates, especially neonates in the NICU, who are extremely premature, who have had surgery and prolonged lines, also are prone to getting infective endocarditis. So the clinical scenarios that they're usually going to present you with is a child with congenital heart disease who presents with fever that is not explained and fatigue. These can be pretty subtle. Or a child with congenital heart disease with new onset congestive heart failure or conductive abnormalities. They're usually going to have fever. Usually they can present with abrupt onset of sepsis or presence of vascular lesions in the soft tissues or mucous membranes. And persistently positive blood cultures in a structurally normal heart should also clue you into the diagnosis of endocarditis, again, especially with Staph aureus. So the most common bugs that I would remember, viridin strep is the most common cause of infective endocarditis, especially in a child with previous heart disease. Staph aureus is most common in a child without pre-existing heart disease. Okay, so I would definitely remember those. So you're admitting a 16-year-old boy with non-complex congenital heart disease because of a 3-week history of fatigue, low-grade fevers, and night sweats. You're concerned that the boy has infective endocarditis. What's the best study to confirm your diagnosis? Is it a blood culture, a sed rate, an echo, or a serum complement? You could only choose one. Which one would you do? Okay, very good. So a blood culture is the most sensitive measure of, or a blood test to detect endocarditis. These are some of the symptoms of endocarditis that you should be familiar with. Remember, some of these can be pretty subtle. So fever is present in everybody. Splenomegaly is common. Petechial lesions, embolic phenomenon, and new or changing murmurs. Osler's nodes, Ross spots, Janeway lesions, splinter hemorrhage, all are rare. These are the splinter hemorrhage you would see. These are the Osler nodes, which are usually painful. Janeway lesions are painless. And these are the Ross spots that you might see on retinal exam. So positive blood culture is present in almost all children with infective endocarditis. The only time it is not is with previous treatment with antibiotics. Inflammatory markers are usually high. These children are usually anemic as well. They may have hematuria and low serum complement, but it's not a slam dunk. So persistent bacteremia, most helpful. We generally obtain 3 to 5 cultures when we suspect the diagnosis highly sensitive. Immunologic phenomenon may also be helpful. The presence of glomerulonephritis, a low C3. And echo is also helpful, but not as sensitive as a blood culture, about 60 to 80% sensitive with a TTE. We don't usually do transesophageal echoes in young children, but you do increase sensitivity when these are done in adults. I wouldn't worry about antimicrobial therapy for the boards because you really need to know the bug Empirically, certainly you want to treat for viridin strep as well as Staph aureus. These are some of the surgical indications: heart failure, uncontrolled infection, a very large vegetation, embolic events are all surgical indications. So we're going to conclude with prophylaxis. So patients with which of the following diagnoses should receive antibiotic prophylaxis for dental procedures? COARC, secundum ASD, post-op VSD with a patch leak, aortic stenosis, or a PDA? Okay, very good. So the answer is C. So the current guidelines, which were developed in '07, were revised and much more restrictive in terms of what they recommend for prophylaxis. And this is based on the fact that bacteremia resulting just from daily activities is much more likely to cause infective endocarditis than bacteremia associated with any dental procedure. So because of this, only a very small number of cases might be prevented by antibiotic prophylaxis, even if prophylaxis was extremely effective. So the conditions for which prophylaxis is indicated are listed here, and you can certainly review these. Certainly any prosthetic valve or prosthetic material, previous endocarditis, congenital heart disease which is not repaired or completely repaired with prosthetic material within 6 months, repaired congenital heart disease with residual defects, certainly anyone who's undergone a cardiac transplant. These are the conditions for which prophylaxis is recommended. And all dental procedures that involve manipulation of gingival tissue or periapical region of teeth or perforation of oral mucosa will need prophylaxis. All these other procedures here that you can look at do not need prophylaxis. Antibiotic prophylaxis also is reasonable for procedures on the respiratory tract, certainly tonsillectomies, infected skin and skin structures, musculoskeletal tissue. Again, these are only for patients who have the previous underlying cardiac conditions that are listed in the table. Not usually recommended routinely for GU or GI tract procedure. And you can look at the rest of these. And then the final question is, what antibiotic would you use for standard prophylaxis for a dental procedure for a child who needs prophylaxis? Use Amox, azithromycin, cefdinir, or Bactrim. Okay, almost 100%. Okay, so amoxicillin, these are the recommendations. You should be familiar with amoxicillin. And if you have a penicillin allergy, you can use cephalexin, which is the first generation cephalosporin, clindamycin, or a macrolide. Thank you very much. We are 8 minutes over, but we're going to take a 15-minute break, and we'll make up the time later, I'm confident. Thank you very much.